Recording on. Hello, and welcome to another session of updates in surgical pathology from the OU Path Department. I have a guest today, Dr. Wenyi Luo, who has an MD and PhD and recently joined our faculty after training in GI and surgical pathology at MD Anderson. He's going to talk to us about things we need to know about hepatic adenomas and related liver tumors. So, Dr. Luo, the floor is yours.
Okay, thank you. Thank you for the introduction. So I'm gonna share my screen. Dr. Hassel, can you enable the screen sharing?
Of course, of course.
So today I'm going to talk about hepatocellular adenoma with a focus on molecular classification and individualized management. You know, this is not a common tumor that we see on a daily basis, so it's better to have a systematic view to look at it. So to summarize, hepatocellular adenoma is a clonal hepatocellular expansion, and it's characterized by monotonous hepatocytes with absence of bile duct. And they have unpaired arteries, as you can see here. And this is one of my cases. You can see that these hepatocytes are bland and monotonous. And usually we should not see architecture atypia, or the architecture atypia is very minimal. So this is my tumor. You can see that the junction between tumor and the normal liver is sharply delineated, and you don't see infiltrated border, and you don't see thick plates. You don't have pseudoacinine or reticulin loss. And in addition, you should not see cytological atypia or only minimal cytological atypia. And you should not see lack of small cell. You should not see small cell change or mitosis. And usually the tumor should occur in non-cirrhotic liver in general. However, there are exceptions. Some patients are predisposed to hepatocellular adenoma. For example, patients are hormone, for example, patients on estrogen, androgen, or patients with genetic syndromes like MODY or glycogen storage disease. And hepatocellular adenoma are not without complications. The complications include malignant transformation in 5% of the tumor and hemorrhage in 15 to 20% of the tumor. And it's important to note that these complications are not equally distributed in different hepatocellular adenomas, and some of them have a higher risk of complications. So that means that we need to have a good classification system so that we can identify those patients at risk. So this is the most recent molecular classification of hepatocellular adenoma. As you can see, that it includes some of the previously known hepatocellular adenoma with characteristic histological features, such as hepatic nuclear factor inactivated hepatocellular adenoma, inflammatory type, beta-catenin exon 3 mutated type, and unclassified type. However, in addition to that, this classification system also identified some additional groups, including beta-catenin exon 7, 8 mutated hepatocellular adenoma, and sonic hedgehog activated hepatocellular adenoma. And it also demonstrated that some of the inflammatory hepatocellular adenoma also have exon beta-catenin mutations, such as exon 7, 8 mutation or exon 3 mutations. And it's important to know that the beta-catenin exon 3 mutated hepatocellular adenoma have risk of malignant transformation. It can become a hepatocellular carcinoma. And also, it's important to know that the beta-catenin exon 7, 8 mutated HCA does not have significantly increased the malignant transformation rate, and it's usually in young patients. And the sonic hedgehog activated hepatocellular adenoma has significantly increased risk of hemorrhage. In some series, up to 70% of the tumor can have hemorrhage. And also important to note that some of the inflammatory hepatocellular adenoma with exon 3 mutation will also have malignant transformation. So these are several hepatocellular adenoma with characteristic histologic features. And this is HCA with HNF inactivation. As you can see that it is characteristically have steatosis with loss of liver fatty acid binding protein with IHC. And this HCA with beta-catenin exon 3 mutation, it has some cytological and architectural atypia. As you can see that these are actually some pseudoacinine. And characteristically, they have beta-catenin nuclear stain, as you can see. And this is the inflammatory type HCA, and they have dilated sinusoids with chronic inflammation, and immunohistochemically, they have SAA and CRP positivity. And our task as a pathologist is to identify this type and also identify some of the tumors in this type with beta-catenin exon 3 mutation. And it's important to recognize that the beta-catenin stain is not without a problem. And this is the beta-catenin stain patterns that you can see in beta-catenin exon 3 mutated hepatocellular adenoma. And this is a pattern we want to see and we expect to see. However, sometimes we are dealing with these patterns. And this is exon 3 mutated HCA with only one nucleus positive for beta-catenin nuclear stain. And this is another HCA with exon 3 mutation, beta-catenin exon 3 mutation with no beta-catenin staining, with no beta-catenin nuclear stain at all. So that's when why we need glutamine synthetase. Glutamine synthetase is downstream of beta-catenin pathway, and it can be used as a surrogate marker of beta-catenin activation. And in contrast to beta-catenin stain, this glutamine synthetase stain is diffuse. No matter is heterogeneous or homogeneous, it is diffuse. So it's very helpful, especially on biopsy. And this is, there are at least 5 staining patterns for glutamine synthetase. These 2 patterns, namely perivascular pattern and the weak heterogeneous pattern, are typically seen in beta-catenin exon 7, 8 mutated hepatocellular adenoma. These are the tumors without malignant transformation risk. These are the patterns we see in exon 3 mutated hepatocellular adenoma. And this is a moderate heterogeneous pattern. This is, intense heterogeneous pattern. And this is intense homogeneous pattern. These are the 3 patterns we can see in exon 3 mutated hepatocellular adenoma, and they have a risk of malignant transformation. And this is a pattern, it's called the periphery enhancing pattern. It can be associated with either one, so it's not very helpful, especially on the biopsy. Lastly, hepatocellular adenoma with sonic hedgehog activation. It does not have any particular cytological architecture features to help with diagnosis. However, you can see hemorrhage at different stages. This is the early stage and this is the late stage, kind of organizing hemorrhage. And these tumors can be positive for ASS1 and the PTGDS, which is prostaglandin D2 synthetase. So based on the this classification, the management of hepatocellular adenoma is actually personalized or individualized. So the management is dependent on the complication and the risk factors. So if the tumor is complicated, for example, it has bleeding or malignant transformation, then the definitive treatment is needed. If there is no complications, it will depend on the risk factors. For example, if the size is greater than 5 centimeters, if it is symptomatic, if it is male with dysplasia or beta-catenin activated subtype, the patient should undergo definitive treatment. Otherwise, we should withdraw the hormone and observe the patient for 6 to 12 months and see how it goes. If the tumor regress, then it can be observed. If the tumor progress or the tumor have other risk factors, in particular sonic hedgehog mutation or activation, then the patient should be surveyed for bleeding. So this is pretty much what I want to talk about. Thank you so much.
Thank you, Wenyi. That was very helpful. This is a complicated topic, And as you say, not a frequent one, but one with clearly great implications for us to identify and help the clinicians to know how to manage these patients going forward, to avoid the bleeding complications, and to catch the potential risk of malignancy cases. So I appreciate your updating us on that genetics, and we will sign off and until next time, and thank everyone for joining us in this program today.